safety in more safety. And the most dangerous phrase in the language is, we have always done this way. We need not change it. And our thought process for next half an hour should be that safety has to be taken care of, safety first, because we are on a highway. And I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital and Endosurgery Institute. Whole of the talk will be on these questions which are always in our mind. Why safety is important? What is the magnitude of the problem? How the safety can be attained? And who are the people who have to be taken care of? Where it should be done? And when the safety is more important? As we take the flights also, we don't ask who is the pilot today. But till date, when the patients come to the surgery OPD, then they always ask that who is the surgeon who is going to operate me. So have we become as safe as we should be? Talking on a wrong note, negative note, this is one of the stone in the cemetery, and in this it is written that Mr. So-and-so, Deputy Superintendent of Police, has died because of the negligence of this hospital and this doctor. Similarly, can you imagine, this is in Bhubneshwar, that one of the funeral ceremonies of the person, they are carrying a banner, and on the banner it is written, so-and-so has died because of the negligence of so-and-so doctor, and he or she should be punished to the maximum. So one move can become a movement. And all of us have read about this, that doctor beaten to death in Assam after the worker dies. What I mean to say, this is the magnitude of the problems which we are seeing day in and day out. And thinking is that in this Formula 1 racing car, it just takes, you will see, just takes 8 seconds for all the 4 tires to be changed, the car to be fueled, and then the pilot goes, the driver goes. So it is a teamwork. And if we have seen Senna dying in May 1994, after this Formula 1 racing car, then the president of Formula 1 Racing Car Association said that this is the last time somebody has died on the track, and we should make sure that no one in future dies. And I think lot of work had been done for the safety. Most important was, failure is not an option. But we should introspect within ourselves. Are we giving this kind of training to our younger lot, that failure is not an option? And to commemorate this, in God we trust, all others must bring data. It was a beautiful statement. So what I have done is that I have brought the data from Lancet. For example, in February 2009, the third commonest of death, the global burden of death, is still the post-operative death after the ischemic heart disease and the stroke. What I mean to say, even if we are not writing on the certificate that the cause of death is iatrogenic or some post-operative complication, but still it is the third commonest death. And the beautiful article by Haynes had reported that 234 million operations are done every year globally, and 1 million people die. 1 million. And 7 million have disabling complications. Most important aspect is 50% of these complications are preventable, and the major complications are of the order of 3 to 16%. In developing countries, you can see that the mortality rate is also higher, is 5 to 10%, and surgical site infection is of the order of 14%. Even if we start saying that the complication rate is 0.5 or 0.8, but if you multiply with millions of people, then you will realize that so many people are dying because of these complications. And medical error is the third leading cause of death in US. All of us know that, after the ischemic disease. And can you imagine that so much of adverse events have been reported, and there are more reports, more events which are not reported. So if we combine them all, then one will come to know that every year 313 million surgeries are done, but total deaths within 30 days is of the order of 4.2 million. What I mean to say that if we add on the deaths because of HIV, malaria, tuberculosis combined, still we are far ahead than them. What I mean to say that we should make sure, as was presented by Dr. Mittal also, that 44,000 to 98,000 Americans, we should not blame only the developing countries. Even in US, the people are dying every year as a result of errors in care. And if the complication rates are varying from 0.5 to 5, but most important aspect is that half of the complications are preventable, and the principles of surgical safety are inconsistently applied. Human mind is human mind. Can you imagine last week only in US, in New York, one of the person has got the kidney transplant done and he was a wrong patient. So you can imagine the processes involved. So many processes have been involved, and ultimately the patient has got the wrong treatment. Other person should have got it. Similarly, 7% of the population are exposed to a serious medication error, and this is very, very important. And beautiful publication had come in which they had seen that the wrong site surgery, and each year 1,500 to 2,500 surgeries are done on the wrong site. And as obvious as hand surgeons, they were surveyed, and more than 1,000 surgeons participated in that, and they admitted that once at least in their life they have operated on a wrong side. 21% of the 1,000 surgeons. You can imagine, as open as hand, they have been operated in a wrong direction, in a wrong manner. The science of safety has matured, but basically thought process is that why can't we have the similar kind of safety as the aviation model is? I will be touching in a few minutes on this, that because of the communication errors, diagnostic errors, poor judgment, and inadequate skill, that is ultimately leading on to so much of challenges. And is it either a omission or commission of the act, or it is an error of execution or error of planning? But more important is, there is a deviation from the process of care, and that is causing the harm to the patient. Would you be surprised that this patient, young patient, had come to a hospital with gastroenteritis, and in the IV fluids, I don't know what had happened, and she had to ultimately be amputated because of, it was analyzed later on, because of the ergot which was present in IV fluids. So these are the medication errors. You can see the patient had come for a GI surgery, but this is the mask which has been applied onto the face, and with the ETO or non-sterilization, this kind of gift we are giving to the patient. So don't practice until you get it right, practice until you cannot get it wrong. I think this is very, very important. And as all of us are taught in our undergraduate and postgraduate days, that decisions are more important than incisions. When not to operate is more important than anything else. And to my mind, if I can give this kind of feeling in my fellows in both Gangaram Hospital and Bhatia Global Hospital and Research Institute, that a split second becomes eternal. For example, if this kind of accident can occur, and still the pilot Saranbarkar saved all the 270 people just because of the presence of mind, and he landed onto the Hudson River and ultimately saved everyone. Still, we should introspect that has the surgery become as safe as the aviation model? But if we compare, you can see the odds of dying in an air crash is of the order of 1 in 10 million, whereas the odds of dying in a hospital is of the order of 1 in 300. You can imagine the state, why this stage difference is there. That is the reason that we are not asking today who is the pilot who is going to take us. Because when they are in the cockpit, and it is written in Indigo Flight, also I have taken a photograph, that flying is a serious profession. Do not carry your worries beyond this point. And what we do, in our theaters is this, that when we go into the theater, patient is under spinal anesthesia or whatsoever, we are replying on a mobile phone to our relatives, to our wife or children or whatsoever, whosoever, that we will be there this time, don't worry, I am finishing my surgery, 5 minutes I will take. So, and the patient is also listening. So we have become insensitive. And similarly, the distractions lead to disasters. The laparoscopic surgery is being going on, but still one can see the football being played. And can you imagine that this is a small episode which had occurred, and it has touched my heart, that this flight, Jet Airways had taken off from New Delhi, from Mumbai to, and it was supposed to land at London. And on the way, the pilot had gone to the toilet. But the co-pilot who was there, he set some frequency of 132.980 rather than 890. And ultimately, he lost contact on the German airspace. And the Germans thought that they are being invaded by some plane. And then they flew in three planes to shoot that Jet Airways plane. But by the time, as luck would have it, the pilot had come out of the toilet. He sat and he saw that we are not having any contact with ATC. And he realized that the frequency has been mismatched, and he corrected the frequency, and then everything was safe, and the Mumbai flight, it landed into London with 3 more planes from German airspace. So what I mean to say is small. In our theaters also, all of us have seen, we do so many workshops all over the country and internationally. We find every minute the assistant is saying, sorry sir. Sister is saying, sorry sir. I always say that sorry ka role sirf ghar mein hai. And if we make a small mistake every time, if we carry on adding on, you can see the mathematics, that's 37.8. And if we do not make the mistake, if we care less than what we are required, you can see the difference, 0.03 and versus 37.8. In last few years, as Dr. Mittal was also discussing, even Jacobius in 1910, he had told that it is puncture itself that causes risk. And still the risk is there of abdominal wall excess. And we strongly believe that to err is human, to refer is divine. To err is human, to cover it up is unpardonable. Most of us, the surgeons, are on a denial mode, and we cover it up, and that is unpardonable. Causing an injury is a mistake, but misdiagnosing is a negligence, and mismanaging is a crime. So we should definitely make sure, for example, in laparoscopic surgery, I tell my fellows that all entries, all exits must be shown. You should never ever leave defects more than 10 millimeter for the future hernia to come. For example, this was one of the patient, sleeve gastrectomy had been done. 2 days after the sleeve gastrectomy, the patient comes vomiting, and then when we get the CT scan done and then go in, and one can see that because the main surgeon must have gone out, and assistants pull out the cannula like this, and because of the change in pressure of pneumoperitoneum and exterior, this intestine gets jutted into the port and ultimately leads on to such kind of complication. Thinking is that even a small split second can become eternal. So we should remember that life's greatest lessons are learned at the worst times and from the worst mistakes. And life is too short to learn from your own mistakes. Today also, in this era of 2019, we can see such kind of, can you imagine, post-open appendectomy, not any other, post-open appendectomy, the patient continued to have fever for 1 month, and the surgeon gave or stepped up the antibiotics day in and day out, but the fever was not subsiding. And then when the patient came to us, we got the CT scan done, and we did the laparoscopy, and you can see during the laparoscopy, this is the post-appendectomy. I'm not saying we have enough of, all of us must have enough of experience of post-cesarean, post-hysterectomy, post-complications, but post-laparoscopy, post-open appendectomy, such a gossypioma or retained foreign body or textiloma or corpus hellenium were there. What I mean to say that why can't we have that kind of feeling, check, recheck, cross-check, counter-check, check and check? If we have that kind of feeling, if we have conveyed to our younger colleagues, then only it will change the habit. Our thinking is that why blame the others? Surgery is an attitude, and we should get out of our own way. Once we improve every day, and this improvement, what is Kaizen? Anyone knows what is Kaizen? Yes, what is Kaizen?
We followed in Japan for improving the self, where they have a discussion and
Good, very good. This is a Japanese word, and this is used in the technology jargon also. Kaizen means continuous improvement. If you are thinking about continuous improvement within your own, if you are introspecting, then you will be better than yesterday. Otherwise you will, and this one small step can change your life. And it is the continuous improvement through introspection. And we always say that to be good, anticipate one step, to be great, anticipate 3 steps, and then you can become a great surgeon. When the why is clear, the younger people, we always tell them retract this, retract that, or hold that. But if we tell them why this step is being done, what are you doing, and ultimately what is the way that we are going to help, this is going to help. This is when the why is clear, the how is easy. I think most of us as teachers have the responsibility that we should make them not the fast surgeons, but we should make them the safe surgeons. And can you imagine that in bariatric surgery, which we do in both Gangaram and Global, that most of these surgeons are on a denial mode that they do not give the prophylaxis for thromboembolism. But all of us have seen the symptomatic DVT and pulmonary embolism is as high as 6.4%. Most of the times this occurs after discharge. And actual incidence is underreported. And if we do the autopsies of those people who have died after bariatric surgery, we would find that 8 out of the 10 autopsies are because of the pulmonary embolism. And if we still say that my patients have not died, other patients may have died, I think it is absolutely wrong. So what we do is that we strongly believe on Caprini score model. We make sure that all the risk factors are objectively, evidently calculated, and then we offer them the ambulation, the stockings, the DVT pump. Every patient has to get the DVT pump before the induction rather than after the induction, and every patient has to be mobilized within 4 to 6 hours after the surgery, even if he is having a weight of 290 kg. But the patient, the dictum is that every patient has to be mobilized so that we have the prevention of these complications. What I mean to say, for example, when I am doing the sleeve gastrectomy, the last stapler when we are firing, we always say that when there is doubt, there is no doubt. So fire that staple rather than save that money of 10,000 rupees and then face the consequences of leak. So thinking is that there is safety in more safety. And a mistake repeated more than once is a decision. And we have been seeing, all of us have seen such kind of CT scans or X-rays. You can see 2 years post-cesarean, the patient has been visiting the gynecologist very often, but none of the times the X-ray was done. And in this situation, what we did was that we have a low threshold of going in with diagnostic laparoscopy. We went in and we could find so many adhesions, and this is the artery forceps. And at that time, we knew it, that we are going to have an open incision, but this open incision can be sighted better if we have done the diagnostic laparoscopy. If we would have found out that yes, it is badly embedded into the rectum or into the colon, then site of incision would have been different. What I mean to say, so we can always use, and then once we did this, and we could take out the artery forceps. Similarly, 7 years post hysterectomy, you can see the artery forceps have been lying in, but none of the surgeons had taken care of. And I would request especially our younger colleagues to read this book of Atul Gawande, the checklist manifesto. And this checklist has made such a difference that it can reduce the rate of post-operative complications and death. And most important is, can you imagine that read back, hear back errors? I strongly feel that we are giving the instructions which are wrong. And that is why the people who are following it are following it in the wrong manner. So thinking is that if we give the instructions, this pilot and this pilot, both of them have been given the instructions that you are going to collide, so take care. But the SpiceJet pilot had responded back to the ATC that yes, now I can see the Indigo flight coming from across and we are taking the precaution. And read back, hear back errors. If you do not read back what you have heard, that means you are not going to be safe. So thinking is that communicate, 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 over communicate. And we believe on these checklists, you can see that small steps have been taken care of, not that bigger steps of WHO. I am not against the WHO checklist, but our thinking is that every hospital, every theater should make its own checklist based on this WHO list also, so that we are not going to miss any aspect of it. There are no mistakes, only lessons. And as I mentioned before, also surgery is an attitude, and the only disability in life is a bad attitude. So if we have the will, and the will should be stronger than the skill. If we have the will, then definitely safety is more important. And even if a small change which we are making it in our protocol, that will save so many lives. So no one can motivate you if you are not willing to do it for your own self. Thank you very much for your kind attention. Thanks a lot.
This is a common thing that is happening every day. The safety is safety. But in India, probably the rural-based surgeons are not taking at all the safety measures, and the people also, they do not know that it is the error of the doctor. They depend on their fat, and they blame their fat only. This is happening in India. In big institutions, this can be arranged. But in the rural areas, I can say that even the tuberculosis, vasectomies, they are done in high schools, in temples, small temples in village. Even hydrocele harness are done in schoolhouse, village school, there is camp, health camp. So in that, what safety will take? Except in gloves and one set of aprons, nothing is there. And for your good information,